On behalf of CHEST, I would like to welcome the viewers to this Giants in Chest Medicine, which is truly a landmark Giants in Chest Medicine with Dr. Richard Irwin, who really needs no introduction. He has been part of the fabric of the CHEST organization as editor-in-chief of the journal CHEST for 14 years, president of the American College of Chest Physicians, and has made seminal contributions to the field of pulmonary critical care and sleep medicine. So with that, Dr. Irwin, can you tell us a bit about how early life was for you? What was family life for you growing up?
I was born in 1942 in New London, Connecticut. My sister Bobby was born 4 years before, and she's my only sibling. My dad was a physician, Harold Irwin. He was in solo practice and featured himself as an internist and then a cardiologist, although he never really took any official cardiology training. And my mother was a social worker, but as time went on, she spent most of the time at home. It wasn't clear to me before the age of 7 that I had ever set up what I wanted to be. I remember running around with cowboy boots, maybe wanting to be, a fireman or a policeman. But I remember starting to go on house calls with my father when I was about 7 years old. When we went out, sometimes it got dark, and when he was looking for the street number of the house that he was going to go into, he would turn on his spotlight that was on the outside of our Buick to find the street number. And I thought that was the coolest thing. And I figured, if that's what a doctor does, turning on spotlights, that might be something that I might want to be.
Sounds like very formative sort of experiences with your father.
Yeah, and then we ended up moving. We used to live with my grandmother, and then my dad and mom bought this huge house. It was in a commercial part of New London, Connecticut, and his office was downstairs. We lived on the second floor, and then we rented on the third floor. But I remember long stairwell and descending down the stairwell so that I could hear what was going on. Of course, I shouldn't have been doing that. And I was struck by what appeared to be the good feelings that the patients had towards my dad. And I think those experiences, set me up for probably wanting to be a physician.
And then tell me how things sort of evolved from there in terms of kind of figuring out you wanted to apply to medical school and how you decided that.
I think, so this is a little bit out of order, but I had a 5th grade teacher. Her name was Betty Jones. And I'm sure I had a crush on her. And it was her first year of teaching. This was in the 5th grade. And I remember that she was the first person who made me feel good about myself outside of the home. I remember giving her my Hebrew school workbook that had all sorts of stars on it. On the cover of the book, because I've recently had the opportunity to look at this again, said best pupil in the class, and I gave it to her as a gift. About 40 years later, she was cleaning her house, and I was at UMass in the office, and I got a letter saying, I'm not sure if you are the Richard Irwin that I'm looking for, but if you are, I need to return something to you. She goes on in a letter to say that her husband looked up to try and find me because we hadn't seen each other in about 40 years. And there were 3 Richard S. Irwins in a telephone directory of 88 million phone numbers in the United States. And there were 3 Richard S. Irwin physicians in the United States. And I was the only one in New England. And so she figured that because I came from New England, my father was a physician, and I told her in the 5th grade that I was going to be a doctor, that I must be that Richard Irwin. And so I was that Richard Irwin, and I called her up, and we had the opportunity when I became the president to actually meet. It was a few years later when I was initiated as the president. And so the American College of Chest Physicians arranged for her and her husband to be at the meeting.
How special.
So that took you forward 40 years, but I think that I was destined to become a physician.
It sounds like it. And what a powerful position as a teacher to be in, to have such an impact when you're so young, to give you that positive reinforcement and encouragement. And then looping back later in your career, that's really amazing.
Yeah, teachers are very important.
Absolutely. Tell me about high school and then undergraduate school and how things evolved. Did you stay around the same area that you grew up in, or?
So I was in the public school system. I went to New London High School. I was a very good student. My dad had gone to Tufts undergraduate and Tufts Medical School.
Oh, okay.
And I applied to a number of medical schools, but decided to end up going to a number of colleges and medical schools, and decided to go to Tufts. So I ended up going to Tufts College and then Tufts Medical School also.
Your father must have been very happy about that decision.
I'm sure he was.
Yes.
Yeah, he was.
Yes, that's fantastic.
And then really loved being in the Boston area, was very happy with my education, and my first choice was to become an intern and resident at the Tufts New England Medical Center, and then I ended up going there.
And how did you decide on internal medicine? Was it immediately kind of something that appealed to you, or did you have several things that interested you and then you kind of narrowed it down?
I know I didn't want to be a surgeon, and interestingly enough, during one of my rotations at the Jamaica Plain VA that was affiliated with Tufts, I ended up, when they closed the surgery service there for Tufts, about 20 years later, they sent out all of your evaluations. And the chief of surgery actually said, he's a very bright guy, but thank God he's not going to become a surgeon.
No.
So,
I think I would have gotten the same kind of evaluation.
So, I liked thinking about problems, working my way through it, and interacting with patients. And so, I was drawn to medicine.
Was there anyone, just out of curiosity, during medical school that helped you come or arrive to that decision, or anybody during that period of time that sticks out for you?
Louis Weinstein was the chief of infectious disease, Robert Schwartz, the chief of immunology, William Schwartz, the chief of renal, all very famous men who I think were role models that, I impressed me.
So, internal medicine residency, and tell me about your experience with residency and how then you came to get interested in pulmonary and critical care medicine.
Sure. Internship and residency in the 60s was tough. So our program, I was on every other night, every other weekend for 2 years. So that was 24 months of that.
Wow.
During my internship, the Hong Kong flu struck Boston. I mean, it was obviously, a pandemic. And many of my fellow interns actually succumbed, and I found myself on, this is no lie, for 3 straight days.
Wow.
Very tiring, And I remember at the end of the third day, or close to the third day, that I basically hit the wall. And I remember being in the ICU, and the patient's first name was Stella, and I was taking care of her. She was in septic shock from a staph pneumonia associated with influenza. Mm-hmm. And I remember that I just had to get to sleep. So I called the resident who was sleeping and told him that I was going home. And he said, well, you can't do that. And then I hung up and was going to leave, which obviously would have been very bad. Mm-hmm. And I remember walking to the GI floor, and as I was going to get my bag, there was a ward, and I looked at a monitor that was in the hallway showing that somebody was in ventricular fibrillation.
Wow.
So I called the code, ran in, took care of the patient, and I disappeared for nearly 2 days. They couldn't find me. And they got the police involved.
Wow.
Some people thought that I was AWOL and that, I had quit the program. Across from this ward, mm-hmm. Now it's in the daylight, it's about a day and a half to 2 days later, she was going to give a patient a bath. And she opens up the door where the bath is, and I am lying in the bathtub, and she sees me, screams, thinking that I'm dead.
Oh my goodness.
Woke me up, and they didn't fire me from the program because they figured I was an AWOL.
Yeah.
But they found me.
Oh my goodness.
So the night call, the day call schedule in those days could lead to something, to like that. So the 80-hour work week makes a lot of sense today. Got through the residency. We didn't have really a pulmonary service at that time. So this is like in 1968. So the blood gas machine had just become clinically available in 1967.
That's incredible.
We didn't have any assist control mechanical ventilators other than what we referred to as the IPPB machines. So we only had controlled mechanical ventilation. I felt that I really didn't know very much about pulmonary disease. But I wanted to be a cardiologist. So I decided that to be the best cardiologist, to distinguish myself from all the other people who would become cardiologists, is I would first take a pulmonary fellowship. So I wanted to go to the Cardiovascular Research Institute at the University of California in San Francisco. And
on the other side of the country.
On the other side of, well, it was the best place. That's where Julius Comro was in those days.
I see.
I applied to Columbia, I applied to a few other places.
Now, was it pulmonary and critical care? Or
no, this
just
was
pulmonary at
critical
this time?
care there was no such thing.
There was no such
in
thing.
those days.
Got it.
Heard from the program, and they said, bright guy, but you haven't done a senior residency. In those days, when you do 24 months of internship and junior residency and you wanted to be a subspecialist, many people decided they had had enough medicine, they were going to go do their subspecialty. So I decided that's what I was going to do. But University of California in San Francisco said, you better take another year first. So I decided at that point, we'll drop the pulmonary thing and I'll become a cardiologist. And advice I would give anybody is don't do what I did. I only applied to one cardiology program. It was at Emory with J. Willis Hurst, who was LBJ's cardiologist. It was, at that time, the best cardiology program in the country. And the people who I had mentioned before, William Schwartz, Robert Schwartz, Louis Weinstein, huge names, said, wherever you want to go, we'll get you there. So I had an interview at Emory. At the end of my internship, I go down, and they didn't have any record that I was supposed to be there. Now, Dr. Hurst is known as a tough guy. So he comes out of his office and he says, well, we're not going to interview you, so you might as well go home and you can come back. And I said, you know, this is my only chance to come down here. It's not like I can afford all these trips. He goes, okay. So he takes me to medical grand rounds. This is now videotaped throughout Georgia. I'm sitting in the front row. I have my charcoal gray suit on. And the chief of GI is giving medical grand rounds. And he's talking about hepatomas. And his idea of giving medical grand rounds was to pimp the audience for 45 minutes. So for 45 minutes, he asked all sorts of questions of the audience. They knew nothing. And then he sees me in the front row. This is the speaker. And he asks me 3 consecutive questions about hepatomas. And I happen to know the answers.
Wow.
At which point, Hurst decides we should interview this guy. So they take me around, and he says to me at the end of the day, you'll hear from me in 2 weeks. You'll come down here and be a cardiology fellow. So I go home, now back seeing patients. 2 weeks passes, I don't hear from him. 2 months passes, I don't hear from him. It's now February, and 3 to 4 months left of the year, and I have nothing else to do except go to Vietnam. So there were deferment plans at those times. They were called berry plans. And I, fortunately, just the luck of the draw, got a full, what was called a full berry deferment, and I had the opportunity to also pick the Air Force. So I finally get a call from Hurst. It was snowing. Don't remember what day. I think it was a Friday. He calls me and he says, I'm making my calls now. We want you to come down here and be a senior resident. And I say, I want to be a cardiology fellow. And you told me months ago that I was going to hear from you in 2 weeks, and I haven't heard from you. So he said, I'm going to offer you a senior fellowship. You come down here, you do a good job, then we'll make you a cardiology fellow. And I said, I don't want to do that. Of course, I had nothing else to do other than to fight in the Vietnam War.
That was quite brave.
Not smart. So he says, so you're turning me down? And I said, I'm turning you down. He said, okay, I'm now going to offer you a cardiology fellowship.
Wow.
So I said, I'm confused. He said, listen, I don't have much time to talk on the phone. I'm offering you a cardiology fellowship. Come down here, you start in August. I said, I'd like to go home and talk to my wife and call you tomorrow. No, I need to know now. And I thought it over, and I decided, and I told him that I didn't see myself spending 3 years with him. So I turned him down, and I had nothing to do.
Wow.
So now it comes time for me, I have to call the Defense Department to tell them I'm ready, you know. And the only way I wasn't going to go to Vietnam is actually if you finished a specialty, you know, training program. So I delayed a few weeks. I remember it was 10:30, the sun was out. I'm in the basement of the hospital. They had windows down there. And I get a call from Harry Fritz, who was the chief of pulmonary at Columbia.
I see.
And he says to me, I noticed that you asked for an application. We sent you one, but you never sent me anything back. We have a NIH-funded training program. Do you have anything to do next year? And I said, no. He said, well, do you want to be a pulmonary fellow? And I said, I don't know. I have to go home and talk to my wife. So he said, you're our last choice. You're my last call. We didn't fill our program. Don't have any other applicants. If you want to become a pulmonary fellow, The program is really sort of like geared towards respiratory physiology, but you'll have enough clinical experience. Show up August 1st. So I showed up August 1st, and that's how I ended up in pulmonary disease.
Wow. That's a great story. I mean, so you really, at such a, I don't know that I would be so brave, at such a young period in your life, you really stuck to your principles. And yeah, that comes to my observations of you just always acting with integrity.
Yeah. When I told my wife the story, she said, "What were you doing?" But, she stayed with me, and we ended up getting our orders and ended up in Biloxi, Mississippi, where we fought the Vietnam War for 2 years at Keesler Air Force Base.
Oh, wow. What was that experience like?
Interesting.
Yeah.
It was interesting.
Yeah.
So we lived on base. On-base housing was phenomenal. It's about an hour and a half from here, New Orleans. Didn't spend a lot of money on anything in Biloxi. There really wasn't much going on in Biloxi then. And we would come to New Orleans maybe 2 out of every 4 weekends to go to restaurants. It was great on base. Being off base, we enrolled our oldest daughter, Rachel, in a Baptist daycare, and everything was great until they found out we were Jewish. And then they said, Rachel can't come here anymore.
Oh, my goodness.
Because she's Jewish. So, I think in those days, I think, diversity was not...
different time, yeah.
As good as it is today, although we certainly can do better today.
Absolutely.
Yeah. So 2 years, I ended up being the chief of pulmonary, the chief of ID. I ran the micro lab. I ran the pulmonary lab. Participated in helping to run the ICU. Saw things that I would have never otherwise seen. Wow. Published about 10 articles from interesting things that ended up seeing down there.
Incredibly productive.
Yeah. And then the Vietnam War ended, and it was time for me to get a job, and I decided that I wanted to be in academic medicine. Wanted to be back in New England, and was fortunate enough to understand that Brown University had started a new program. Sid Brayman was the chief. He had been there for 1 year. He and I immediately hit it off, and I joined Sid in Rhode Island. There for 4 years, then was made an offer I couldn't refuse at University of Massachusetts, and then to become the chief, and then ended up there. And I've been there ever since.
What year was that?
That was 1979, January 1979.
Wow. And you've been at the University of Massachusetts since that time?
Yeah, 40 years.
Wow. That's incredible.
Yeah.
So I didn't realize, so your first kind of leadership roles and experiences were not at University of Massachusetts. They were when you were on base, and you said you were a chief of pulmonary, chief of infectious disease, and that must have been a period of growth and kind of understanding how to kind of navigate that role.
Yeah. So it was just jump into it and, try and figure it out. Things worked well. Always tried to create teams. And in those days, so the fiber optic bronchoscope, which made pulmonary actually it's the kind of specialty it is now, became available in the United States in 1970. And I remember towards the end of my fellowship, the bronchoscope, I don't know if you knew or heard of Mike Eisman. So Mike Eisman was in one of the pulmonary programs in Columbia programs at Harlem. And so he got one of the first bronchoscopes in the United States. and he would travel around the city scoping people. But I never had the opportunity to learn how to do that until I joined SID. And then we ended up teaching each other, the way you wouldn't want to do it, and we don't do it today, how to do that procedure. And I taught myself how to do all the other procedures.
Wow.
And then taught myself actually how to be the chief of all of those other, positions in the Air Force.
So tell me more about the critical care medicine component of your journey, and as this is such a passion of yours.
Yeah. Well, as you know, if you train in pulmonary, you take care of patients on ventilators. And I think even before the American Board of Internal Medicine decided that it should be a special qualification and a subspecialty, pulmonary people were doing critical care. So were some surgeons and anesthesiologists. Jim Rippey is somebody who I've worked with for a number of years. When he was a resident at the Mass General, he actually had the thought that, we should be able to write about critical care and define what the core material is that people practice when they're in the ICU. And so he thought of the idea of writing a manual. He got Little Brown Publishing. So Little Brown still publishes, but their medical division is long gone. But this was in the 80s, the early 80s. So Little Brown said, sure. So Jim was actually a medical resident. He was then going to become a cardiologist, but nobody at the Mass General in the pulmonary group would help him out write the pulmonary section. Since he had connections at UMass, where I was, he asked me if I would help write the pulmonary section and some other sections. And so I agreed to do that, and the manual did so well that Jim was able to talk Little Brown Publishing into having a textbook of intensive care medicine, and that's what our textbook is called. We actually are just going to start our 9th edition, so we published our 8th one a few years ago. And the first textbook, the first edition, came out in 1985. That book allowed us to capture all the core material that people would need, taking care of patients in ICUs. And then I think because it captured the substance and identity of what critical care was all about, I think that, and it was the first textbook in critical, one of the first textbooks in critical care that I'd like to believe that it helped, get the American Board of Internal Medicine to decide that, critical care should be a specialty.
That's incredible. That's so formative for our field. And it's a classic textbook that we all have used. That's incredible.
The other thing that Jim was able to do was get Little Brown to publish the Journal of Intensive Care Medicine. So it's a little niche journal now, but it was one of the first journals actually to cover, it was mostly review articles to cover topics in critical care medicine. So Jim Rippey and I still work together. He was a cardiologist. He now is fitness and nutrition, and he's had less and less to do with the textbook.
I see.
And now I'm of an age where I'm about to turn it over to actually Craig Lilly. But the book is alive and well.
That's great.
And so is critical care.
Yes, absolutely. Yes.
Yeah.
So it's incredible how you have been leading the way with many of these firsts, including this intensive care unit textbook. You've also been involved with one of the first characterizations of a fungal organism, interstitial lung disease, and transtracheal oxygen. So can you share more about those experiences?
Yeah. So, as I had said, when I was in the military, I was also the chief of infectious disease. And there was a lot written about how poorly expectorated sputum was in identifying what actually the cause of the infection was. And one of the procedures, this is again before the bronchoscope and protected specimen brush quantitative cultures, could be used. One of the procedures was transtracheal aspiration. And so it was one of the procedures that, again, I taught myself. And identified a lot of interesting things. I mean, I did it when I was actually a house officer and then a fellow when I was at Columbia, and then when I was in the military. And so being the chief of infectious disease, using transtracheal aspiration, I was able to identify primary meningococcal pneumonia, which actually is around, but most people don't try and culture for it. And although transtracheal aspiration, you take a large bore needle after you numb up the neck and through the cricothyroid membrane, you end up passing this catheter, this needle through which you pass a catheter. We actually studied it for safety. And Heimlich was looking to actually develop transtracheal oxygen.
I see.
And so read the articles that we had published about the safety of transtracheal aspiration and figured that it would be okay to put a catheter where we had been putting the catheter before and instilling oxygen. So in his original articles, he credits our safety information from transtracheal aspiration in coming up with transtracheal oxygen.
So that laid the foundation for the development of the transtracheal oxygen mechanism.
When I was, again, in the military in Biloxi, Mississippi, there was a corpsman who got into an automobile accident, and he was in the surgical ICU. He had this terrible infection in his eye. He actually lost his eye. And we isolated an organism that, from a smear, looked like it probably should be mucor mucosis. One of the zygomycetes. But we sent it off to the CDC because it wasn't. And it turned out to be an organism called Saxonea vasiformans, which had never been described before. So, I was just there in the right place at the right time and knew where we had to send the stuff off to actually get it identified. So it is one of the zygomycetes and can cause human infection. So that's how that ended up happening.
Wow.
When I was a fellow, one of the things that we were studying was the pulmonary circulation. And for 2 years, I actually worked in the dog lab doing basic research. And one of the things that we wanted to do in studying regional circulation was to see what would happen if you caused unilateral disease. And so complete Freund's adjuvant was the substance that was injected into animals. You'd have to put a swan in, blow up a balloon so that this substance would only go into one lung.
So you mentioned some of your research experiences in the dog lab in particular and your exposure to basic science. Can you tell me a little bit about your research exposures along the way, basic, translational, clinical?
Yeah, so during my fellowship, so the Columbia group was very interested in the pulmonary circulation. So Andre Cornon and Dickerson Richards got the Nobel Prize for basically showing everybody how to take care of shock and actually using right heart catheterization. And so the lab was that was their major interest. The year before I became the fellow was the last year that they wanted to show the fellows what it was like to be right heart cathed. So all of the fellows before our year actually ended up having to be catheterized in our laboratory. maybe somebody decided that it wasn't a good idea after that, so I escaped that particular event.
So, Dr. Irwin, can you tell us about mentors that you've had along the way and how they have shaped your career?
Mentors are very, very important. The ones that immediately come to mind are my mother. She's the one who actually brought patient-focused care into focus for me. Jim Dolan, who was my first chairman of medicine at University of Massachusetts Medical Center. That's what it was called at that time. Jack Wegg, who really helped me refine the way I write and think critically. And I would say Cindy French, who has worked with me for 40 years, and how to keep focused on what we need to do and how to be organized and get things done.
Mm-hmm, mm-hmm. And how has that carried through in terms of your role? Because you are an incredible mentor and sponsor for others.
I think, so I just stopped after 14 years of being the editor-in-chief of Chest, and I was the 7th editor-in-chief. The 5th editor-in-chief was someone by the name of Al Sofer. And in many ways, I wanted to be like Al Sofer. So in the late 70s, myself, Sid Brayman, and Mark Rosen decided to write a review article on cough. It had never really been done before. Mark Rosen was a third-year Brown medical student looking for something to do. He went to Sid Brayman and said, "Hey, I'd like to do something with you for a few months." And Sid said, "Go see Richard." So Mark came to see me, and I remember that as a fellow, now I'm a junior attending, but as a fellow, I was interested in something called Arnold's nerve. So if you ever stick a Q-tip in your ear or somebody's examining your ears and you cough, it's because a branch of the vagus nerve, the auricular branch, Arnold's branch, actually is involved in the cough reflex and the nervous system connections. So I wanted to know more about cough. So sent Mark off, and he came back 3 months later with a shoebox full of 3x5 cards. And we just decided introduction, physiology, pathophysiology, treatment, diagnostic, evaluation. We just divided things up from whatever he had collected. Wrote this review article, sent it off to 10 journals, and got rejected by 10 journals. And I had heard that Al Sofer loved being a mentor and loved helping people. Mm-hmm. So he was the CEO of the American College of Chest Physicians and also the editor-in-chief of Chest. I called Chest. They transferred me to him. He answers the phone. He speaks to me. He said, "Send me the manuscript. Sounds great." Looks it over for a week, got back in touch with me and said, "We don't publish these kind of things in Chest at this time. I'm about to become the editor-in-chief of the Archives of Internal Medicine. Mm-hmm. Give me about 6 months, do this to the manuscript, do that to the manuscript, send it to me at the Archives of Internal Medicine, and I will publish it." And he published the article, very kind, very helpful, and I like to believe, it's like destiny that all of a sudden I became the editor-in-chief of the same journal. Mm-hmm. But it was that interaction with Al that, made me understand how important it is to be helpful to others, to be a mentor. Mm-hmm. Mm-hmm. That's my mentoring story.
Mm-hmm. Mm-hmm. Fantastic. I was wondering if we could go back in time compared to where we are right now in the timeline and understand a bit more about how you met your wife.
Yeah. Diane was an ICU nurse at the Tufts-Wingham Medical Center, and that's where I did my internship and residency. In those days, there wasn't a separate ICU rotation, so if one of your patients, we had subspecialty wards, but let's say if I was on the GI ward and the patient became septic, then that patient would go to the ICU, and I would not only take care of the people on the GI service, but I would also travel to the ICU. So the first day in the ICU, I see a nurse who's taking care of Betty, who I was going to be picking up, and Betty was getting peritoneal dialysis. So she had a subacute glomerulonephritis, wasn't from streptococcal disease, and she needed peritoneal dialysis. Diane was on her hands and knees. This was the day of short skirts. Diane's head was lower than her butt. And as I came upon the bed, I said, I have to see what the other end looks like. So I crawled under the bed and came face to face with Diane. Not expecting her to be as beautiful as she was and is. The only thing that came out of my mouth was something really stupid, which was, "Hi, I think I want to have children with you."
You really said that? With your first
that.
encounter?
That was my first encounter.
Oh, my
And
goodness.
then there wasn't another encounter for months because she would not have anything to do with me. We just celebrated our 50th anniversary.
Oh, congratulations. That's wonderful.
Yeah, thanks.
Wonderful. Is there anything else that we didn't talk about that you want to discuss?
I really feel good about what we've done with critical care at UMass. So we've changed the behavior. After changing the environment. We brought on telemedicine, so we have a very successful tele-ICU program. But I think that the biggest contribution that I've been able to make is in the area of cough. And it all started with Al Sofer helping us out with that review article. Because that review article taught myself and Sid and Mark, that we could spend the next 3 to 4 decades and still not be able to answer all the questions that needed to be answered. So, I mean, it actually launched me in particular, clinical research career.
So if you could go back in time and talk to your younger self, what kind of advice would you give?
I would tell myself that when I made a mistake or I misspoke and then would spend a week going over it again and again and again in my mind, that it's not necessary to do that and to continue to beat yourself up. When you say something that you wish you hadn't said in front of somebody, I tended to just perseverate about that, and the other people have moved on. So I would tell myself to be kinder and more gentler to myself.
That's great. More self-compassion.
Yeah.
Yes. Tell me what you're most proud of in your career.
I think that I'm most proud of my family and what they've become. I have 4 phenomenal daughters and 9 grandchildren. After 4 daughters, ended up having 8 grandsons and then have 1 granddaughter. But I'm most proud, and I know my wife Diane is also on how they've turned out. Especially since one of the more difficult things to do is to balance work and family. And I wasn't always certain that I did it right, but seeing what they've become and how they've turned out has made me feel proud that I think I did it the right way.
So, Dr. Irwin, what kind of pearls of wisdom or advice would you give those who are more junior in their career?
I think it depends upon what people want to end up doing. For all physicians, burnout is a huge problem. It's a very complicated story, but just like when you invest financially, it's always good to be diversified. And so what I like to tell prospective trainees in pulmonary critical care and sleep is it's a good idea to actually take a specialty that has multiple pathways, for work that you would end up, doing. The older that I've gotten, even though I chair critical care at the present time, most of my clinical activity now is in the ambulatory setting, taking care of patients. So I think diversification is something that I would recommend, especially for people who are going to go into clinical medicine. I think if you wanted to become a clinical researcher and you wanted to be successful, make a name for yourself, a really good way to get started, even if you're in a big group working in a certain area, is to actually do a systematic review on a certain topic. Because if you ask the right question, the key clinical questions, you'll be able to find out, if you do a high-quality systematic review, what hasn't been done or what needs to be done better. And so that's a way of, I think, launching a clinical research career.
Well, it has been a true honor for me to conduct this interview with you, Dr. Irwin, and you are a true giant in chest medicine. It's been an honor.
And I want to thank you for interviewing me. I'm honored.